atropine doses that were used in this particular patient. Any thoughts about her dosing?
Yeah, I had also reviewed that with some of our REI colleagues because I was curious about that too. They did say that if they were maybe managing the case, they probably would have started a little bit lower with the dosing. Not too much lower. They said it wasn't unreasonable what she was put on, but definitely she probably could have been started lower and increased at a slower rate. Um, I
Yeah,
also will,
I'll jump in on that. I mean,
yeah,
I think it's shocking, to be quite honest,
yeah.
that this was chosen. I mean, these patients will, it's difficult with PCOS. I mean, I understand that there's a certain threshold that you have to reach to get the response you're looking for, but you always start low. I'd rather start much lower in a patient like this, or maybe even combine it with oral
Mhm.
agents to prevent this exact scenario from occurring. 4 amps a day is a hefty dose for a 31-year-old and a really risky dose, in my opinion, for someone with this profile. And I'm not surprised. I mean, there are danger signs all along the course of her journey, too. I mean, as you said, and it's important to point out, an estradiol of 20,000 plus. I mean, that's really asking for trouble.
Mhm.
So, I think she was fortunate that she got through it okay. What do you think about shifting gears a bit? I mean, what do you think about having 14? I think you said blastocysts. Uh, how's she going to manage that?
Yeah, so I these questions that you're asking, I actually asked all the same ones too. The REI, kind of that I talked to, had basically said she said no one really needs 14 blastocysts. She kind of was saying that, you don't have to shoot that high. Like, what's anyone going to do with that amount? And so knowing that that's what she is capable of producing, probably the team could have, like we said, decreased her medications and don't have to shoot for the moon here. Like this patient can definitely produce eggs and oocytes and blasts can be made. And so probably, this dosage did not have to be carried out because probably no one needs that many blasts.
Yeah, I guess one never knows,
Yeah, yeah.
but you're right. I mean, the goal is one healthy blastocyst, giving you one healthy baby at a time. Although, again, it is nice to have supernumerary embryos in
Right,
the freezer, especially if they're euploid.
right.
But it does create some ethical dilemmas for some patients. I've seen it. That's the kind of thing you'd like to discuss with patients before you start. I've typically seen fellows, and I think they're taught this, to ask how many children ideally would you like to have? And then, if somebody says 3 or 4, you say, well, we hope to get 3 or 4 or 5, normal euploid embryos for you in one retrieval. But, again, it's difficult for an infertile patient to ask such a hypothetical question, to answer such a hypothetical question as that. I think the expectation again should be not like how many embryos can we make for you in one sitting, and consider that a success, because the price the patients pay immediately is OHSS risk, which this patient exhibited. And then secondly, after they have a baby, they commonly do, but I think these days, and certainly at RMA, probably 65 to 75% of the embryo transfers give a birth. So again, she's very, very likely to have a baby from all of this work. But what happens, people shift their thinking after they've had a baby or two. I've seen it many times. And they suddenly start thinking of their frozen embryos not as a possible child, but as a child. And it becomes very difficult for them to know, in terms of embryo disposition, what do I do with these embryos? And it can create some real problems for people because they don't really want to discard them. So I just bring that up.
With 60 seconds left, I see Dr. Dunn has her hand up.
Hi, Nina. I'll be quick. I was just curious if her post-op day one visit, when she had all those symptoms, if that was a scheduled follow-up visit since she had so many risk factors, or if that was like a problem visit, and if you think that it should have been closer follow-up if it was not a scheduled visit.
Yeah, I'm pretty sure that was a problem visit. I don't think that this was not a scheduled. I think she had called and talked about her symptoms and had come into the office, but definitely that's an important point that patients who are already known to be high risk for OHSS should have very, very close follow-up before and after their retrieval, because that's when they're in the highest window for exhibiting their symptoms.
All right.
Thanks, Nina. Great job.
Thanks.
Thank you so much, Nina. Excellent job. All right. Well, it's time to switch gears. and switch over to grand rounds in just a minute. I'm going to ask Dr. Sauer to introduce our grand round speaker. But in the meantime, regarding attendance, we'll be taking attendance using the participants list. So if your name is displayed clearly, you'll get full credit for attendance from the department. If you're calling in or there are two people on the same computer, you can email or text your attendance to me or Michelle or Beth. And with that, Dr. Sauer, are you ready to introduce our speaker?
Yeah, very happy to do so. And on the theme of REI, which is nice when our themes coincide with the talk. It's my pleasure to introduce one of our many clinical faculty at RMA New Jersey, Angela Leung, who's a clinical assistant professor over there. The residents and students probably see many of our attendings coming and going. It's such a busy place. But with the academic focus in mind, it's really great when we are able to get them to give us talks as we do. Angela, I believe, grew up in the Midwest in the Indiana area from looking at the CV. She can correct me if I'm wrong, but has New Jersey roots because she went to Princeton as an undergrad before returning to Indiana University for her medical degree. Came back to the East Coast at Tufts University for residency, followed by a REI fellowship at Harvard, Beth Israel. And as RMA, they are a very busy clinical group and get really great clinical training. She's double board certified both in our specialty and REI. She's an excellent provider, and it's my pleasure to have her address a really important topic for people to hear because there's so much of it with recurrent loss. And so, Angela, thank you for doing this and welcome.
Thank you so much, Dr. Sauer. Yeah, thank you for a great introduction. I will be talking to you guys today on recurrent pregnancy loss, and I really tried to keep this as clinical as possible and not dive too much into the weeds. But let's get started. Okay. So I have no disclosures. What we're going to talk about today is first, we're going to talk about the definition of recurrent pregnancy loss, review the prevalence, risk factors, and different etiologies of RPL. We're going to talk about what's evidence-based in terms of both evaluation as well as treatment, and their benefits and limitations. And then I'm going to spend a little time at the end talking about the psychological impact of RPL, which I think a lot of times really doesn't get thought about or addressed adequately. And then specifically how we can better take care of our patients by individualizing care for them. Okay, so first of all, the definition of RPL is there's two main societies that in the fertility world we kind of use for a lot of guidance on topics in this field. ASRM is essentially the US group, if you will, and then ESHRA is more of a European organization, and both of them have their own papers on recurrent pregnancy loss. For the most part, the definition is the same. So they both include that if you have at least 2 or more losses, then that qualifies you as having RPL. The important things to note about this is that there is no mention that these 2 losses must be consecutive. So that's not part of the definition, just 2 losses in general. And then where they specifically differ is, well, what counts as a loss? For ASRM, they specifically do say that it has to be a clinical pregnancy, meaning that you documented this pregnancy, it was an IUP on ultrasound, or you have histopathology confirming that. However, the ESHRA guidelines say that no, it could be a biochemical. You only need a positive pregnancy test or serum HCG, and you don't have to have any other confirmation of pregnancy. So it's a little bit more lenient in allowing what is counted as a loss. Now, I'll tell you in clinical practice, most of us probably don't get this nitpicky about it, and we probably follow more in line with what ESHRA says, so we'll count a biochemical pregnancy as a loss. We know that most of pregnancy losses occur within the first trimester, and first trimester losses are in fact very common in all pregnancies. average of 15 to 20%, even in a young population. And of course, this percentage increases with increasing maternal age. However, based on slightly older data of population studies, the previously reported incidence of people who would have multiple losses was relatively low, less than 5% with 2 consecutive and less than 1% with 3 or more consecutive losses. But really, the true prevalence is probably not well understood. And some of this is changing as well because first of all, we are seeing a global rise in diagnosed pregnancy loss. Part of that is some of these definitions have changed a little bit, and there's much improved technology and just patient access and being able to even know when they're pregnant. So many more people now are aware of fertility. They track their cycles, they test immediately. So you're going to get a lot of more of those initial positive betas and then early losses at home, whereas many of those might have gone unnoticed before. There's also a lot more proactive diagnosis and management of early pregnancy. And along with this global trend of increasing maternal age, and rising rates of obesity that all contribute to loss. Now, what is specifically not addressed in any of these kind of RPL statements by the major organizations is the impact of age is actually not directly talked about. But this is obviously impactful, and one of the, I would argue, one of the most impactful risk factors for miscarriage, because we know that age-related aneuploidy increases dramatically as the maternal age increases. And so this is C2C data back from about a decade ago, looking at the rate of loss based on your age group. And you can see that in a young person, let's say less than 35, the likelihood of having 2 or more losses in a row is relatively low. However, if you look at the older age group, and in particular those 44 and older, the likelihood of having multiple losses is very high. And so this maybe should also be impacting the way that we evaluate and treat these patients, meaning we might need to have different thresholds for what we're going to consider to be abnormal. So, this paper by Kute back in 2015 kind of gave the idea that maybe we should be limiting our workup threshold to a patient who technically has a risk of recurrent pregnancy loss less than 5%. So meaning you're going to have a higher threshold to evaluate in an older patient. You're going to wait for more losses to occur before you would evaluate them. Again, in clinical practice, probably most of us don't actually do this, but it is an interesting thing to think about. Okay, so let's talk about risk factors. I talked about age already being one of the main ones. The number of previous losses does increase your risk of subsequent loss, and certainly why you had the loss, like if that issue was corrected or not. And having a history of a successful pregnancy previously actually decreases your risk of loss. So the etiologies of recurrent pregnancy loss. Now, in majority of cases, it's going to be unknown, meaning when you do this workup for a patient, everything comes back normal. We don't have a reason. But the assumption is actually the majority of those cases are going to be from aneuploidy. So obviously not every single person who experiences a loss, especially if they experienced at home, is going to have had the opportunity to test those products of conception. So we won't know, but that's an assumption that we typically make, especially based on age. Out of the rest of the kind of pieces of the pie here, the other etiologies that we see are going to be structural or anatomic issues. That's probably one of the most common ones, secondary to chromosomal aneuploidy. Then you have your autoimmune issues like antiphospholipid antibody syndrome, endocrine abnormalities, infectious etiologies, other types of rare thrombophilias, and environmental factors. So I'm going to first start by talking about chromosomal aneuploidies. So this is essentially some type of genetic abnormality that leads to an abnormal amount of genetic information in the resulting embryo or fetus. And it can be whole chromosome aneuploidies where you have, an abnormal number, or it can be structural abnormalities where maybe the number is correct, but you have translocations. And out of all the losses that we think occur, it's probably upwards of 75% can be attributed to chromosomal issues. Most of these chromosomal issues are of the whole numerical aneuploidies or polyploidies. So true structural rearrangements are more rare. And these result from non-disjunction during meiosis. You can have duplications, deletions, or insertions of entire chromosomal segments. And ultimately, it leads to an imbalance in either the oocyte or the sperm. So it is important to remember that it can happen on either side. And then when the egg and sperm come together, it leads to a chromosomally abnormal embryo. Again, this occurs during non-disjunction during meiosis. We know that the most common type of whole chromosome aneuploidy are the autosomal trisomies. And then monosomies kind of account for a smaller proportion of that, and then tetraploidies, even rare. Interestingly, the most common chromosomes that are involved are 13, 16, 21, and 22, 16 being the most common. It's not really well understood why in particular, but it just seems much more likely for 16 to not separate correctly during meiosis. The distinction to make, and this is one of those things that I feel like comes up on like pre-augs or testing, is the single most common cause of diagnosed miscarriage is Turner syndrome, so monosomy X. Okay. So let's get into a little bit more about like exactly how it occurs and how age plays into this. So one of the reasons that aneuploidy, this non-disjunction issue, occurs and increases with increasing maternal age is that the meiotic spindle becomes more dysfunctional as the oocytes age. So if you remember, the spindle is what actually pulls those chromosomes or chromatids apart during meiosis. So when you have abnormal function of those spindles, then that pulling apart of the chromosomes can happen abnormally. And then you get segregation errors. There's also an age-related decline in the cohesion molecules of when the chromosomes kind of align in metaphase, and then you have, they may not be properly positioned, and then the crossover events get messed up. And essentially all these different confluence of issues leads to abnormal separation. When you get too much DNA in one cell, you can get a trisomy, and then the corresponding one in the other cell is going to be a monosomy. And that's kind of the most common type of segregation error, but there can be other ones as well. And it results in an increased number of aneuploid oocytes. And in particular, this is why age matters so much with on the female side, because the oocyte ages and it just becomes more dysfunctional as it's older. This graph is data actually from a really big RMA study done many years ago that showed this rise in aneuploidy rate with maternal age. And these were based on PGT tested embryos. You can see that in the mid 30s and really even in the 20s, the aneuploidy rate hovers in the 20 to 30%. But as you get into the late 30s and 40s, it dramatically rises so that by the time you're 45, the aneuploidy rate's about 90%. And this is why a lot of clinics do have an upper limit of what they'll allow for autologous IVF, because at a certain point, it just becomes futile of being able to find a genetically normal embryo. Okay, what about structural rearrangements? So these are balanced translocations or and or Robertsonian translocations. Your balanced translocation is most common. It's basically just a piece of one chromosome broke off, stuck itself somewhere else. And so you have the correct total amount of genetic information in the cell as the parent who has a balanced translocation, but then you're at risk of passing on an unbalanced form to the gametes. A Robertsonian translocation is a very specific type of rearrangement that involves the acrocentric chromosomes. So those are the ones with really short P arms. And these are chromosomes 13, 14, 15, 21, and 22. So here's a picture of what that means. So you have two different acrocentric chromosomes with the short P arms. Essentially, the Q arm gets kind of attached to each other at the centromere, and then often the P arm is lost. So this technically is still, a balanced one in a parent, but then you can have unbalanced forms that you would then pass on to your children. And then the other abnormalities that can occur are inversions, either pericentric or paracentric inversions. So again, this is an example of the potential gametes that could result in someone who has a balanced translocation. So this is the parent. You can see they have a flip-flop in this purple and yellow piece of their chromosome. And again, they are normal because they have the correct total amount of genetic information. But then when they go through meiosis, these first two circles on the left side, the first one's a completely normal pattern, and then the second one's a balanced form, just like the parent was. But you could have abnormal segregation, and then you get one type of unbalance that has this extra piece of purple on it and is missing that piece of the yellow, or vice versa, and you would get these unbalanced forms, and these would certainly lead to loss. There's technically way more configurations of abnormalities than just the 4 that are shown here, but this is like a very simplified version of what could happen. And then similarly for the Robertsonian translocations, you start off with this parent that is balanced. You can have a completely normal pattern or a balanced Robertsonian, just like the parent, and then multiple different forms of an unbalanced. If it's possible, it is nice to be able to test POCs when a patient has experienced a loss, because often it will give some information about the reason for that loss. And many times we do find that it is due to aneuploidy. So, if the patient is able to collect the specimen, if they pass it at home, or especially if they get a DNC by a provider, then microarray on the POC should always be offered. You do have to warn patients that there can be maternal contamination of the specimen, or more often what we see is that there's not enough specimen for the lab to actually run the microarray, and then they won't be able to get a result. So it's not perfect. And then sometimes it can actually, because it gives the patients a reason, then it's possible they may be less likely to seek out other causes of RPL. And remember, one of my attendings in residency always like to say this: you can have more than one thing wrong at a time. So don't forget that even if it is confirmed to be an aneuploid loss and they've had multiple aneuploid losses, probably still worthwhile to do a full investigation. Okay, let's move on to anatomical causes of RPL. So this is probably the second most common etiology, and the true prevalence varies from about 15 to 40%, depending on what study you look at. One of the most common or I should say one of the like biggest categories are these congenital anomalies. So the Mullerian anomalies like your unicornuate, bicornuate, and uterine septums. True bicornuate and didelphys uteruses are very, very rare. The septum is the most common one that we see. And it is way more prevalent in patients with RPL. Again, I said that the septum is the most common Mullerian anomaly that we see that's associated with early loss. Bicornuate uteruses are the second most common. They tend to be associated with slightly later loss and maybe cervical insufficiency. And in general, they're just more rare, so we don't see this quite as much. And then you can have your acquired anomalies, such as scar tissue or Asherman syndrome, uterine fibroids or polyps. Now, these are a little bit more difficult to counsel patients on because polyps in general are actually very common, and there's no great evidence to suggest that there's a true association of polyps with RPL. And also no great studies to compare if treatment actually improves anything. But this is, where how we treat things in the fertility world might differ a little bit from the generalist world in that we're a bit more aggressive about these. And I'll talk about it more when I get to the treatment section, but we tend to consider these to be abnormal and recommend removal. The pathophysiology of anatomical issues is mainly that it causes some type of cavity distortion. And so depending on how big the abnormality is, it can significantly decrease the intrauterine volume and interfere with the vascular supply. And then you potentially have mechanical interference in terms of the surface available for implantation of the embryo. Certain abnormalities may also release inflammatory markers that alter the environment that allows for an embryo to implant successfully. Specifically in terms of fibroids, we do know that submucosal fibroids have the strongest association with decreased ongoing pregnancy rates and increased miscarriages. And so these uniformly, we do recommend having removed. Intramural fibroids are a little bit more controversial. We do know that especially at large sizes, particularly over 5 centimeters, they can have detrimental effects, but the jury's still out on whether treating these truly improve outcomes or not. So in general, we don't automatically treat intramural fibroids. Okay, just a few words on antiphospholipid antibody syndrome. So this diagnostic criteria is also something that's very relevant for the residents to know because you get tested on this all the time. And the thing to remember is that you need both a clinical criteria and a laboratory criteria. Now, most of these patients are going to fulfill their clinical criteria by their history of loss. But the interesting thing to note is that the clinical definition of loss, of recurrent pregnancy loss here, is slightly different than what I just mentioned before about the diagnosis of RPL in general. So remember, RPL in general is 2 or more losses. For antiphospholipid syndrome, it's actually 3 or more consecutive losses prior to 10 weeks. Now, again, in actuality, no one waits for 3 losses before they do the antiphospholipid testing, but I just want to make sure that that distinction is made. And then the laboratory criteria, this is also what you need to do. So it's usually, ordered as a panel of your lupus anticoagulant, your anticardiolipin antibodies, and your beta-2 glycoprotein. It is important to remember too that if you have a positive on any of these lab values, it needs to be confirmed on retest at least 12 weeks apart. So technically, one time abnormal value does not meet the diagnostic criteria yet. The pathophysiology of antiphospholipid syndrome is not very well understood because it has to do with the early implantation period, and some of that is still pretty murky. But we do understand that these antiphospholipid antibodies impact trophoblast invasion, and there's a dysregulation in that initial establishment of the vascular connection between the fetus and the maternal compartments. And then there are also these pro-inflammatory cytokines and chemokines that recruit the neutrophils and increase chemotaxis to the deciduum. And then you have this kind of increased cell turnover that can lead to fetal death, premature birth, or early miscarriage. And of course, all increases this procoagulant effect, which is why the treatment for this is blood thinners. Okay, we'll get back to the treatment of that in a little bit. So, okay, endocrine causes of RPL. So the most common ones that we see are going to be the thyroid dysfunction. It's typically not until you have true symptomatic severe hyper or hypothyroidism that you'll see it impacting RPL. Similarly, hyperprolactinemia could throw off regulation of the menstrual cycle and impact loss in that way. And then we also see a connection with diabetes, especially uncontrolled diabetes, and then PCOS. So the effect of hypothyroidism, and I mean clinical hypothyroidism plus the presence of thyroid autoantibodies, have been well established. And so there's no argument for the people who have true hypothyroidism. What's controversial are people who meet this subclinical hypothyroid diagnosis. And there really isn't a consensus on like what threshold of TSH do we use, what do we treat them to. The classic teaching in the fertility sphere was you want people who are trying to conceive to have a TSH of less than 2.5. And that's because that is the recommended TSH level in the first trimester. However, recent studies have actually shown that there may be no benefit to this, and we're likely over-treating patients. There were studies that were done that looked at using a threshold of 4 and seeing if there was any decrease in miscarriage rates if you treated with someone to 4 versus 2.5, and there was no difference. And that's where some of this newer recommendation has come from. And then some studies have also looked at, well, does the presence of antibodies change that? And it does seem that if you have antibodies, you should probably treat to a lower TSH level of 2.5. So right now, this is still kind of in flux, and you'll see different providers sometimes using different cutoffs based on whether they're going with kind of the traditional teaching or the more updated data. So in general, there's kind of two camps right now. There are the people who are still using 2.5 as a flat cutoff. Doesn't matter whether you have antibodies or not, just treat everyone to less than 2.5. That is what we do here at RMA. There are the clinicians who are using 4 as the cutoff now, as long as you don't have antibodies. And then if you have antibodies, treating to 2.5. And again, this is for subclinical hypothyroidism only. So if someone has an established clinical diagnosis of hypothyroidism, you go to 2.5. Okay. Again, like I mentioned earlier, uncontrolled diabetes has an association with RPL. And this is because we know that insulin resistance can be a risk factor. And so the higher the levels of the A1C, the higher the miscarriage rates. And this is why, partly why we recommend that patients with diabetes have their A1C well controlled and less than 7, ideally pre-conception. And again, not just for this, but because we know that will decrease their risk of pregnancy complications as well. With PCOS specifically, we also don't understand exactly how it leads to RPL, but there are some ideas about that. One is the same kind of thinking as with diabetes, because we know that the classic PCOS patient has insulin resistance and hyperinsulinemia, and this can lead to the toxic effects on the egg or the embryo. And then many of these patients have an environment of hyperandrogenism as well, which can impair implantation. And testosterone, antagonizes estrogen, so it can adversely affect endometrial development or the receptivity and that initial establishment of trophoblastic invasion. So potentially will lead to loss. And then obesity and just elevated BMI in general is correlated with increased loss as well. So in PCOS patients, we see that there's a loss rate of sometimes over 50%, just having that diagnosis. So we do know it's much higher than the normal population. Hyperprolactinemia briefly. So prolactin levels are often measured, especially in someone who has ovulatory dysfunction. And we know that prolactin is critical for the corpus luteum maintenance. And so typically the way that it affects cycle regularity is it alters the luteal phase. And of course, the luteal phase is where you have progesterone secretion from the corpus luteum and implantation occurs. So the theory is that when you have dysfunction during that time and with the progesterone production, then you can affect that initial implantation period. Now, hyperprolactinemia is pretty easily treated, and the study was pretty old, from 1998, but that study did show improvement in live birth when they treated with a dopamine agonist. However, I would say more recent data has been a bit more equivocal about this, and it's not super definitive that treating hyperprolactinemia, especially at low levels, has a significant impact. Okay, so now let's talk about when to evaluate. So we go back to that definition of what RPL is, and remember, it's 2 losses. Any losses technically does not have to be consecutive losses. And so we usually will initiate a clinical evaluation after 2 pregnancy losses. And what we test for are for these different etiologies that I just went over. So you want to get a parental karyotype to look for chromosome abnormalities that the parent is actually passing along. So these will typically be those balanced or Robertsonian translocations. And you have to remember that you have to test both the maternal and paternal side, because it could come from either. To look for your structural anomalies, you want to do some type of structural evaluation. And this does have to be more than just a 2D ultrasound. Okay, so depending on exactly what you think is abnormal, you may need to do kind of increasing levels of diagnostic imaging. We typically start with a saline ultrasound because that's going to give you the best sensitivity and specificity for intracavitary lesions. So we do a saline ultrasound in the office, and typically we do a 3D one so that we're able to look at the external contour of the uterus as well. Remember that if you're worried or you're trying to distinguish between a septum or a bicornuate uterus, you must get an external contour of the uterus. So again, either with a 3D ultrasound or an MRI. A normal ultrasound or even a hysteroscopy is not going to give you that information about the external contour. And then you want to do your antiphospholipid screening, those labs that I went over previously, and then your general endocrine evaluation like your TSH, prolactin, and a hemoglobin A1C. Now, there are a lot more tests than just this. So I'm going to go over what's actually recommended by the medical societies and then what's not recommended. So the ones that we talked about before, TSH, yes, definitely recommended. Because so I know the thyroid screening in pregnancy has also changed over the years, where now it is no longer routinely recommended without a risk factor. But remember here that this recurrent loss is a risk factor. So they do meet this kind of clinical criteria to test for TSH. Now, ASRM and ESHRA differ a little bit in whether everyone should get antibody screening for thyroid. ASRM says no, unless you have elevated TSH, and then ESHRA says yes. So, a little bit of disagreement between the two societies. They also disagree a little bit on the prolactin issue, whereas ASRM says yes, test everyone for prolactin, and ESHRA says maybe not, unless that person has symptoms of hyperprolactinemia, such as like a short luteal phase or nipple discharge. I will say that, again, we tend to follow ASRM recommendations here, so most of us will test for prolactin. And similar for A1C, ASRM recommends, ESHRA does not. Now, these are the things that are routinely not recommended because there's really no evidence to suggest benefit. One of these categories is more detailed thrombophilia screening. So like your factor V Leiden, protein CNS, antithrombin, and those things. And that's because the studies have not really shown a true association of these issues with RPL. So of course, the caveat is the patient has like a clinical risk factor for VTE or a family history of VTE, then that's going to be your reason to test them. But if there's no other risk factors and it's just RPL, then this should not be routinely tested for. Similarly, infectious testing is very controversial as well. So some patients, patients love to Google, and I have a lot of people asking me about urea plasma because they read about this as a potential cause of RPL. A lot of these bacteria are part of the normal flora in the genital tract. So it's really hard to know if they're truly contributing to infections that lead to loss, or they're just incidental findings in patients who have a loss. And then similar with chronic endometritis, it's also not very well understood if this truly contributes to loss. We do tend to do chronic endometritis testing a little bit more often in patients undergoing fertility treatment. But we understand that there isn't great evidence for it, and also that the treatment for it, which is antibiotics, doesn't necessarily improve outcomes. So, again, just understanding there's not great data to support that. Similarly, additional testing on the male side is not super helpful either. So there are some patients who ask about like sperm DNA testing, like FISH to look for aneuploidy or DNA fragmentation. There really isn't much evidence to suggest that even if you do find sperm aneuploidy, that's what's contributed to loss. My thesis for fellowship was actually on sperm aneuploidy, and we know, and it's been pretty consistently supported in multiple studies, that aneuploidy rates in sperm is extremely, extremely low and very unlikely to account for in the aneuploidy that we see in the resulting embryos and fetuses. And then you have endometrial receptivity assays or biopsies. There was a ERA test that was a little bit more in vogue in a couple years ago, but recent data again has shown that it's not helpful. So a lot of us have stopped doing that. Also, PCOS testing for everyone without risk factors is not recommended. Similarly, metformin alone without a reason to take it, i.e. meaning like insulin resistance, is also not recommended. Checking luteal phase progesterone is a bit controversial because, first of all, we all do it. But there it's hard because it's very hard to interpret. One of the reasons is that we know progesterone goes up and down throughout the day. So when you get a one-time value and it's slightly low, it's very hard to know, well, is it just low because we caught it at the trough, or is it truly low, indicating an abnormality? And then even if it is really low, is it only a reflection that, the pregnancy is abnormal or what have you, or is it truly the cause of whatever their issue, the issue they're having is? So it's a bit of that chicken or the egg problem. And so the testing and interpretation of it is a little bit problematic. And then, same goes for treating progesterone deficiency, which again, I'll talk about in a little bit. The other thing that's very controversial and we don't recommend is immunologic testing. So like your HLA typing, testing for NK cells, cytokines, all those types of things. There is a whole field now in reproductive immunology, and there are certain physicians and clinics that patients kind of seek out themselves to do all this stuff. And then they get all these treatments with IVIG, glucocorticoids, and lipids. And currently, kind of the position of our medical society is that this is not recommended. There is no consistent data that supports its benefit. Plus, there is a relatively higher risk of harm because a lot of these are blood products. They're expensive. And so it's generally not something that we will actively recommend to a patient. Although, again, there are a lot of people who do end up seeking these out on their own. Okay, so now let's switch gears and go into the management. So starting off with aneuploidies, genetic abnormalities. The main way to treat this is to be able to identify the genetic abnormality prior to conception. So this does require a patient to do IVF so that we can do PGT or pre-implantation genetic testing on the embryos. For people who have a translocation that they're passing along, then we would want to do PGT-SR, which stands for structural rearrangements. And this will actually look at, if the resulting embryo has a balanced or an unbalanced complement of chromosomes. The test specifically cannot distinguish between like a normal and a balanced. So all it will tell us is that it has a balanced subset and that this is a normal embryo. And the likelihood of finding a balanced embryo is going to be dependent on that specific type of rearrangement. Also the age of the woman, because you also need it to be euploid in general, the correct number of total chromosomes, and then also whether the abnormality comes from the mom or dad. And once we can find a genetically normal embryo, then these patients' pregnancy rates are very, very high. And you've really dramatically decreased that risk of loss. And it's really important that these patients all get very detailed genetic counseling, both from the clinical side, meaning like what does this genetic abnormality actually mean, as well as laboratory genetic counseling. So, specifically on the limitations of the test. And our patients at RMA do get both of those from a clinical genetic counselor and our genetics laboratory. Now, what about just general aneuploidy? The parents don't have a chromosomal rearrangement that they are passing along. So PGTA still can be used to identify aneuploid embryos prior to conception. And we do know that for women at older ages where you have a much higher likelihood of having aneuploid embryos, this is going to be of benefit because it's a selection tool, right? And it's all about probability. So if, for example, a 42-year-old has a high probability of creating an aneuploid embryo and then hence having, no pregnancy or losses due to that, then my selecting for the embryo that is normal, you're going to be able to increase her overall success rate. What remains a little bit more controversial is, does it actually benefit people at younger ages? Because the probability at younger ages should be that they have a higher likelihood of randomly having a euploid embryo. So does PGT actually benefit them kind of in the long run? And you know, a lot of studies suggest that it's not necessarily better in terms of their overall live birth rate. However, I would argue that it's faulty to look at just kind of cumulative live birth rate as the ultimate endpoint, because one of the things that is very important in patients going through this recurrent pregnancy loss is first how many more losses it will take before they reach that successful pregnancy, how much more time in general it will take, and then the emotional and psychological toll it will take before they reach that successful pregnancy. So one huge benefit of PGT is that it gives a lot of patients that sense of reassurance that they are putting in a genetically normal embryo, that will reduce their risk of loss to about 10%. And it's one thing that is taken off the table that they don't have to worry about anymore. So it is definitely a viable option. It is one that we frequently do offer to our RPL patients. Kind of talked a little bit about this already, the advantages and disadvantages. Again, increasing the cumulative live birth rate in women with advanced reproductive age. And it also helps to narrow down the number of embryos, or like the kind of prioritize the best embryos. So especially if someone has a lot of good embryos, then it helps us determine, well, this is a subset that will give you the best chance. But like I mentioned, it doesn't necessarily improve that cumulative live birth rate in younger patients. It's not cost effective because it is very expensive to go through all this, especially for someone who theoretically doesn't have an issue getting pregnant. It's more that staying pregnant. And then, you know, some of this is also kind of what was mentioned in, I think it was M&M you guys were doing with the case study. Like, what do you do with these extra embryos that you potentially have? Or even the ones that are determined abnormal. Some people have ethical issues with discarding them or you know, kind of making decisions on the fate of certain embryos. Okay, let's talk about uterine abnormalities. So typically, if these are surgically correctable, we do recommend correction. So with your congenital malformations, the only one that can be surgically corrected is the uterine septum. You would do a septoplasty. These are relatively simple. They're very effective. Patients do really well, even with huge septums. They sometimes do have to be done in more than one procedure, but we see that the term delivery rate after correction is very high. And so these are really satisfying to do because, you know, you see an obvious problem, you can fix it, and often, you know, that patient can just conceive naturally after that and doesn't need any additional treatment. Fibroids. I mentioned before that submucosal fibroids, we uniformly recommend treating these because they have been associated with poor pregnancy outcomes. With intramural fibroids, it's a little bit more controversial and it becomes a very individualized decision based on the size, where it is, if the patient has other symptoms like mass effects or pain, bleeding, and then, you know, if it's changing the shape of the cavity, even if it's not technically impinging on the cavity. So a lot of this will be a very, you know, specific conversation between the patient and the provider to decide what might be best in their situation. Polyps, I mentioned before, are also controversial. From kind of a evidence-based standpoint, there isn't a lot of great evidence to suggest that polyps truly affect loss. But again, we do almost uniformly take out most polyps. The exception might be like if someone has a teeny tiny little polyp in the lower uterine segment, where we think it's far from where a pregnancy would typically implant, then we might say that's not clinically significant. But especially if you have a polyp right in the center of the cavity, we do usually recommend that these be removed. And then your intrauterine adhesions, these are also very easily correctable as well through hysteroscopy. Now, of course, it depends on the extent of adhesions. Most people do not have true Ashermans where the cavity is obliterated. Those can still be attempted to be corrected through multiple staged hysteroscopies, but sometimes those get really, really difficult and scar tissue just keeps recurring. And those are patients who may ultimately need a gestational carrier. But most patients have like 1 or 2 small adhesions that can be easily corrected. Okay, antiphospholipid syndrome. So the established treatment for this is dual therapy with aspirin and Lovenox, and studies have shown that dual therapy is more effective than monotherapy. And however, there's no evidence to support the routine use of anticoagulation if someone does not have this diagnosis, so like the unexplained RPL patients. I'm going to try to go a little quicker because we're almost out of time. And then other treatments for like the endocrine abnormalities like thyroid disorders, hyperprolactinemia, diabetes, you of course want to treat all of those. And then lifestyle modifications as well. And ultimately, some people have uncorrectable issues, and you may have to talk to them about using donor gametes or gestational carrier. The most important thing about all of this is that these patients all should be offered psychological support and counseling, because this could be very, very devastating. And we often forget this piece of it because we're concentrated on like the quote unquote medical aspects, but this is just as important in terms of their overall care. Let me talk a little bit about unexplained recurrent pregnancy loss. So unfortunately, this actually ends up being the majority of patients who I see that come to me for RPL, and that all of their testing is normal. And it's both good and bad, because I tell these patients when there's nothing technically wrong, you actually still have a very high chance of being successful on your own without additional intervention. However, it's very frustrating because they don't have an answer. And then when we don't have an answer or something to treat, then it's very difficult to just give empiric therapies and also to tell them how to prevent this from happening again. So it is a frustrating situation to be in. A lot of times we give these patients progesterone, again, not because there's great evidence. In this trial that I have here in particular was a big trial that was done several years ago that showed that supplementing vaginal progesterone is actually not helpful in increasing the incidence of live births, but we still do it, partly because it's cheap, there's minimal side effects, and it helps the patient feel like they're doing something, and also helps the provider feel like they're doing something. So the risk is relatively low, even if the benefit is not necessarily like proven. And so it is something that we still do offer patients. Of course, having that counseling that it doesn't definitively work. Okay. I'm going to skip some of these lifestyle things because I do want to talk about the psychological impact. So pregnancy loss has an immense psychological toll on these couples, and a lot of them struggle with the same type of stress and anxiety that patients struggling with infertility do as well. And so it's really important to offer that psychological support and counseling. A lot of patients will blame themselves. And that's the biggest thing that I think we as providers can always do, is to reassure them that this is not something they did to cause. A lot of times we don't have an answer, which is, again, very difficult for them. And so it's just allowing that, that support from their providers and reassuring them that they can still be successful, that will help them in this. A lot of them want a reason for why that happened. And that's why it's also useful to offer them this evaluation if they've had 2 or more losses. But especially if there's no answer, they can still feel really out of control. And so this is where, I talk about kind of individualizing care, meaning like when you veer off the path of using evidence-based medicine, a lot of times people may not technically meet the criteria for testing or meet the criteria for having a certain type of treatment, but there may be some type of psychological benefit to treating them or testing them. And this is where you do have to have a very honest conversation with them about the pros and cons, the risks, the benefits. And so, for example, things like empiric aspirin, Lovenox, progesterone that I mentioned before, these may be something that a patient wants to do because they want to feel like they have some control over the situation. And if they're willing to accept those relatively small risks, then it is something you can do. Similarly, doing IVF and PGTA for someone who's only had one loss ever, but it was aneuploid. Some of these patients are so emotionally devastated by their loss that they cannot even comprehend trying on their own again because they are so traumatized by it. And so even though, yes, they, technically they may have good outcomes without additional intervention, they just can't. And so, there is a role, I think, for doing things that are outside this evidence-based practice where you can help the patient from a psychological and emotional standpoint as well. And same goes for early pregnancy monitoring. We know that monitoring never changes the outcome of a pregnancy. You cannot rescue a pregnancy that is destined to fail, but oftentimes it will help patients have peace of mind, or they want to know earlier if there is a loss. That really helps them feel supported. Okay, so just to sum up, we know that a lot of miscarriages are random, sporadic. Age is the biggest impact. A majority of RPL cases will not have a clearly defined etiology, and sometimes interventions do have to be multifactorial. A lot of these patients will end up being successful without additional intervention, but it's really important that you, in addition to like the medical aspect, that you offer the psychological support and counseling as well. Okay, thank you. Sorry, I went a little over time.
Thank you so much, Doctor. Thank you for that excellent review. Are there any questions? Oh yes, go ahead, Dr. Sauer.
Just a comment and then a question. Of all the slides you showed, especially for residents and students to be aware of, which I have used for many, many years, is the Lund data from 2012 in the Green Journal, showing the natural history of people with lots of losses, even up to 6 losses.
Yeah.
And those were without interventions. And so I think, it's an overwhelming tsunami of information when you look at the big field of recurrent loss. But the one thing to always keep in mind is if the patient has basic anatomy and basic age for reproduction, the prognosis for having a child, even without success or without an intervention, is actually quite good. So the things that you mentioned, which are important, very important to identify, and to the point you made over and over again, so much of this is unexplained. It's not without hope because, again, most of these patients, if they stay together, which that's the psychological part of this, it's in play, they do eventually succeed. And so I want to just emphasize that. And along those lines, because so many of our patients, especially, at our continuity clinics and so forth, they have the same problems, but they don't have resources. So if you were working in a federally qualified clinic with Medicaid patients or uninsured, what essential things do you think the providers should at least order or try to order that can stay within the cost limitations of what these patients bring?
Yeah, that's a great question. So certainly one test that is very expensive is going to be the karyotype. So often that's one that we kind of forego early on because that one can cost a lot of money. And actually, even with a lot of patients who have insurance coverage, sometimes it doesn't get covered. So, the karyotype is probably one I would forego. I think a structural evaluation at minimum with an ultrasound will be helpful. Because, you know, with even a good 2D ultrasound, you should be able to figure out if there's some type of Mullerian anomaly, or like a large fibroid or something like that. And so it can at least give you like some type of screening. And then like your endocrine evaluations, like the thyroid is generally pretty cheap as well. And sometimes a patient may not necessarily get that covered if it gets billed under like a fertility diagnosis. So a lot of times we tell patients to just ask their PCPs to order these tests. That can be kind of slipped under a code of like, you know, general screening or something like that. And so those will often get covered even if they have like Medicare or Medicaid. You know, similarly, they can try to get the antiphospholipid panel done with that as well. Although, you know, even though we talk about it a lot in terms of the RPL evaluation, it's extremely rare to find someone that's actually tested positive for it. So I would say that if a patient finds that it is more expensive than they thought, I would, you know, also not worry too much about getting that tested.
All right. Well, we're just about out of time. So again, thank you for this excellent talk.
Thank you. Thanks for having me.
Thank you, Angela. It's a great talk.
And we'll end it here. I wish everyone a safe and successful day.